A little bit, not a lot.
A lot.
Hello, welcome to Doc Talk Live. We're in my office, and I'm via the internet. I'm with Dr. Alex Core. Say hey, Alex.
Hey, how you doing, Brad?
Great, thank you. Thank you for spending some time with me. Alex is a podiatrist, and he's currently located in Wisconsin. Before I get to your background, I just want to say that things are a small world. I know Alex through the tennis world, and we sort of keep in touch here and there a little bit. And he sort of tuned into Doc Talk, and he sends me a message. He says, "Hey, when am I coming on?" And at the same time I get the message from Alex about when am I coming on, I get a message from somebody else via Doc Talk, and it says, "Hey, I have a request for a specialty. I wish you would interview podiatry/feet doctor." I'm quoting. So on demand, Alex comes to me and he says, "Hey, let's do podiatry." And the people that are listening say, "I want to hear about podiatry." So there you go. You were at Johns Hopkins for a while, then you switched to Medical University of Wisconsin. Give our listeners a little bit about your background.
Yeah, I've been practicing 28 years, and the last 14 years I was on the East Coast. I was with Kaiser Permanente in the DC area as well as Johns Hopkins. And then 2 years ago I came back to the Midwest where I'm from, and I'm with Freighter in the Medical College of Wisconsin for almost exactly 2 years. I moved here to Milwaukee in July 2016, and it's a multi-specialty clinic. I'm one of 6 podiatrists. I work with every specialty that any major medical center offers.
So how do you like the tennis up there?
Surprisingly, tennis is good. We're only outside playing tennis maybe about 9 or 10 weeks out of the year. So right now is the heart of outdoor tennis. But no, the tennis here has been a big surprise. It's great. There's a lot of good players, a lot of former college players. So it's actually helped my game a lot.
Did you play more clay courts when you were down in Maryland area, or and what I'm getting at, is there a difference in foot problems between being on a hard court or being on a soft court?
Yeah, there's no doubt there's definite differences in lower extremity injuries when somebody's playing on clay versus grass versus hard court. But back in Maryland and DC, in the summertime, and even there were some winter courts that had clay. And as far as clay court tennis and lower extremity injuries, you're going to see a lot more soft tissue overuse problems, whereas I might be simplifying it to some extent, but in the hard court, you're going to see a lot more stress fractures. You're going to see a lot more joint, particularly the big toe joint, ankle joint, and you're going to have more bone-on-bone issues on a hard court versus clay or that for that matter grass. But that's simplifying it a little bit. But yeah.
All right. I'm gonna get to my writer's question, so I make sure I cover that for her. So she says, "Okay, I have a request. I want to talk to a podiatrist. I've spent a small fortune on fabulous shoes, but I am paying the price for it now. I'm serious. I have bunions on both of my feet and they are disgusting. I know I am not alone. There are many of my friends who suffer from pain in their feet because of her shoes that we once were or just growing older in the wear and tear on our bodies. Also, it's embarrassing to talk about feet, but somebody needs to, and I think you're the one to do it, please." So I think the question has a lot to do with bunions and whether or not wearing ladies' shoes actually causes bunions. Women's shoes.
Well, it's an age-old debate. There's no doubt that women have more bunions in general than men. There's no doubt that women that wear a lot of shoes with a high heel and a narrow toe box, their bunions will be probably exacerbated by their choice of shoes. So for a variety of reasons, one can tell people to, when they do have a bunion, pain is the ultimate guide when it comes to treatment. So for many people who have a mild to moderate bunion, sometimes traditional conservative treatment where there's change of shoe gear, orthotics, etc. can help. It all depends on how much pain they're having. But the one thing is that when you have a bunion, nothing short of surgery when you get rid of the bunion, that doesn't mean that everybody needs to have surgery. So, if somebody's in their 40s, 50s, and has had bunion pain and they've been wearing perhaps very cosmetically appealing shoes, let's say, they need to stop wearing those shoes, and that could help their pain almost immediately. Other people do need some of the other treatments, including surgery.
Let's back up and define a bunion. How do you define bunion? Like, for instance, I have terrible arthritis in my first MTP joint.
Sure.
Terrible. That's not a bunion, though. It's like what I would call hallux rigidus or hallux limitus. I mean, that joint is gone. I'm going to get it out and show it to you in a minute. But what is a bunion versus what I have?
Yeah, it's a good question. I mean, for the lay public, a lot of people get both conditions. It's easily confused. A bunion, by definition, is a large bony prominence on the inside or medial aspect of the foot, sometimes coexisting with deviation of the big toe toward the second toe. And so there are obviously varying degrees of bunions. For some people, it's just the bump and the big toe is straight. Other people do have where the big toe is actually overlapping or being overlapped by the second toe. So that differs from what you have, where there's more of a degeneration of the joint, and you don't necessarily have the structural deviation laterally of the big toe, and that's more degeneration of the cartilage, known as hallux limitus or quote-unquote arthritis of the big toe joint. Now, some people, unfortunately, will have both. They'll have a bunion, bony bump on the inside of the foot, deviation of the big toe or the second toe, and as well as the degeneration of the joint. So there are varying degrees, and yes, the two conditions, medically, you and I would speak of them in different terminology.
So surgery is the ultimate fix, otherwise you're just managing the symptoms. Is that right?
Quite frankly, for both the bunion and hallux limitus, surgery is the last option. Not everybody needs surgery. I've had patients over the years, pretty active patients with what I would call a moderate bunion. Sometimes you put them in orthotic, change their shoes a little bit. Structurally, the bunion 5 years later is the same, but their symptoms are 80-90% better.
So you're accommodating the deformity. Is that what you're doing?
Accommodating the deformity, perhaps layman's terms, balancing their foot biomechanically. There's less pressure on the first MPJ deviation, you have more of a ability with an orthotic to change the shoe gear to kind of allow the second to the fifth MPJ to get some of the pressure. So yeah, you're offloading the area. That's correct.
Are we getting any questions? Any?
A lot of likes, no questions.
All right. So I'm taking off my shoes.
Oh boy.
My new Nike shoes, which until they're broken in, causes me tremendous pain right here, right over the first MTP.
Sure.
And they're broken in, but for the first week I was wearing my shoes with the laces unlaced.
Right.
And I still had to take them off.
Right.
Killing me. And now I'm taking off my sock. I'm glad that my listeners can't smell my feet, but Blake
We should probably open a window.
Blake is dying. So I don't know. Can you see how red it is?
Yeah. Looks like you have no motion there.
I have no motion. I mean, I'm bending at the PIP, but I have a little bit of motion in flexion, but totally blocked in extension. This is by far my worst joint in my body.
Sure.
And if I ultrasound it, it's just bone on bone. And I probably could pull up my x-ray. Showing it to you might take a little while. But anyway, I just deal with it.
Have a question.
You're a tennis player, somebody in our age group, you try to accommodate, offload it. You have the traditional classification of hallux limitus and now progress to hallux rigidus. The differentiation there is how much range of motion you have.
Is it from tennis?
Well,
Or is it hereditary? What do you think?
it's probably a combination, but somebody like yourself who played college there's no doubt that any impact activity like tennis is definitely contributed, maybe the main source of your problem.
I tried what's it called? I think it's called like a Morton's extension. It's a solid, like
Yeah.
carbon fiber thing. And I fell. I mean, I couldn't deal with it. I mean, my balance was so off, I couldn't run with it in.
Yeah, from an orthotic standpoint, I find that both extremes. The Morton's extension is an extension of a hard, either plastic or a cork that extends so that you're kind of rolling off that big toe joint. And some people cannot tolerate it at all, like you mentioned. So what I do then, I'll tell the orthotist, or I'll just take the orthotics to lab and have a significant cutout so that entire first metatarsal will be allowed to plantar flex with limited amount of depth. Sometimes one or the other can help the patient. There's other people that, there's no orthotics going to help, and then we consider, other options, whether it's injections or, some of the newer treatments, if you want to talk about PRP or stem cell, there's all kind of new things out there. How much evidence-based medicine, goes along with these new things is definitely questionable.
So Blake, you were saying there was...
Yeah. So Amelia wants to know, do all bunions need to be surgically removed?
No. Pain is the dictating factor and limiting factor. So, on a daily basis, I see plenty of people that have a mild to moderate bunion. I think it's our obligation, at least as a podiatrist, to offer patients a wide array of symptoms, a wide array of treatment options for their symptoms. Yes, surgery is an option, but I would not go to the point that the person suggested that all bunions need to be surgically treated, because a lot of people change their shoes, modify their activity level, orthotics, all the concerted things that you've done, we can get them 80-90% better. So no, I would say that not all bunions, not every patient with a bunion needs surgery. That would be a better way of phrasing it.
Any more questions right now?
Yep. So my feet hurt every morning when I stand up first thing out of bed. What could that indicate?
So accent there. So typically that scenario there is usually a patient will have pain on the bottom of the heel or the arch. Classic sign of what's known as plantar fasciitis. It's an inflamed ligament on the bottom of the heel. A lot of people think of it as a quote-unquote heel spur, but we all know that 30% of the general population has heel spur on their x-ray and has no pain. So typically pain first step out of bed in the morning is usually a soft tissue type of overuse condition. It can be plantar fasciitis, which is again is heel or arch pain, or sometimes a tendonitis. Sometimes I see posterior tibial tendonitis. Tendon on the inside of the ankle has the same type of first step out of bed pain. But a lot of the things, change of activity. I see so many people, and I'm sure you do too, that are told, well, I weigh 20 pounds too much. My doctor says my blood pressure's high, so they told me to walk or exercise. Now I'm walking for exercise. My blood pressure's better, but my heels are killing me. So I tell every patient, I said, look, we want every person that comes to the office to exercise. I don't necessarily want every person to walk, run, or jump for exercise. So I think it's always, I got to think outside the box. I always tell people, look, stationary bicycle, swimming, water rope, elliptical machine, row machine. These are all good ways to burn calories, and you get the same benefits of exercise without, causing overuse injuries of your feet.
Alex, I'm curious to your comments about. I want to move back from the plantar fascia and go more into the posterior heel, where the Achilles inserts into the calcaneus, okay, where the calf muscle tendon inserts into the back of the heel. Those symptoms also can be present when you wake up in the morning and first step down and walk to the bathroom. Can you make some comments about that?
Yeah, you're absolutely correct. So we all have a muscle in our lower leg, calf muscle, that the Achilles tendon is a continuation of that muscle, and that attaches on the back of the heel bone. And many people, like you said, Brad, will have pain not on the bottom of the heel, but on the back of the heel when they first get out of bed, get out of the car, and it's a similar type thing. It's an inflamed tendon in this case versus an inflamed ligament. But a lot of people get get very excited because they'll say, well, my primary care doctor's got an x-ray and there's a spur back there. I want to have that spur removed. And this is a common scenario. And all too often, it's the fact the patient's not stretching properly, not wearing the right shoe. A lot of the same treatment options that I offer patients with plantar fasciitis, I offer the same treatments for Achilles tendonitis, with the one exception, and it's important that it's emphasized, typically we don't give cortisone shots in or near the Achilles tendon. There are some exceptions, but for the average weekend warrior, this is something to be avoided. But there's no doubt that you have the same scenario, pain on the back of the heel, first step getting out of bed.
What is the right shoe?
Yeah, so the right shoe, I can try to demonstrate because I have the right shoe on. So you can go to, whether it's running shoes, tennis shoes, you can go to all kind of catalogs and say, well, this shoe's for for an overpronate or for an undersupinator, whatever, oversupinator. I found over the years, particularly with the late public weekend warrior, you need to stick with the basics. And all my tennis friends kind of know what I tell them. So when you pick up a shoe to buy, and I don't know if you can see me, I'll demonstrate. Right here in the shoe, this is a dress shoe, you don't want that part of the shoe to bend. All shoes bend here, that's normal. But right in the middle, you don't want the shoe to bend. Now, typically like Crocs, we'll wear Crocs in the home. Right in the middle, Brad, yeah, yours is probably too flexible. Right in the white part, there's a bend in the white part.
It's not bending there.
No, I think you're good. I think those are good.
Okay.
So the point is that, I'll just give you a good example. A couple years ago, I was working a running clinic, and there was a lady who had plantar fasciitis, and she goes, I can't understand it. I bought these 4 pairs of shoes, same brand name, same model, all at the same time. When I wear these first 3 pairs of shoes, she had them all out on the floor, I have no problems. When I wear this 4th pair of shoes, every time I either had a pain during the run or the next morning. So I picked up the shoes, the 3 that didn't bother her were as stiff as this. That 4th pair, which was bought at the same time, then right in the middle. And I think, for me, it was an important lesson that I can, reproduce when I talk to patients or other healthcare providers, because you can't go by what the magazine said. You can't go by what's online. You have to know what, when you buy a car, you look for certain features in the car, and when you buy shoes, you should have the same aptitude, same knowledge to buy shoes, whether it's running shoes, tennis shoes, whatever.
Why is this feature important?
Great question. So,
that's why they pay me the big bucks, Alex.
So the plantar fascia, I think, is kind of the root of all evil. There's something known as a windlass mechanism, but the point is, from this part of your heel to this part is where the plantar fascia is. And there are plenty of people that say, no, my heel never hurts, but the outside of my foot hurts, vernal tendon. I think the big thing, to answer your question, is that part of the foot is really not meant to bend. And if you keep it, half the time in orthotic, what's it do? It supports that part of your foot. So nowadays, we all know orthotics are not covered by a lot of insurance companies. So I always tell the patient, let's look at your shoes before we start talking about orthotics. So the best answer to your question is, if you hold that part of your shoe stiff and rigid, there's less chance of having a lot of overuse injuries. About 20 years ago, I was at the Cleveland Clinic, and we did a study with runners. We had, I believe, 30 runners, and in our group, 15, all of them had plantar fasciitis. 15 of them, we changed their shoe to a shoe that was stiff. The other 15, they continued to run in the shoes that bent in the middle. And it was borne out with our study that what I call the shoe, this is the shape of the shoe that used to be rigid. And in the last 20 years, we have a fad with minimalist shoes, and then people that's now out of favor. Now we have the shoes, the maximal shoes. I think the key thing is, no matter what the description, the semantics is, if you just tell your patients, make sure this part of the shoe doesn't bend, and it doesn't have to be a big, heavy, ugly shoe like this, that usually will help out a lot of patients. It's not the only treatment, but it's usually where I start.
Now let me say something, Alex. I have seen a lot of plantar fasciitis, and I've looked at a lot of shoes, but I never knew to look for that. So I've learned something. So clearly, why isn't this more widely known, or am I just dumb? a combination of both.
No, you're not, Doug. You're a well-educated tennis playing doctor. So, no, I think it's overlooked by a lot of people. I had a patient today or yesterday from California. She saw tonight. She moved here to Milwaukee, and she said, "Well, the doctor said I need shoes with more support." So I said, "Well, what do you think shoes are that have more support? What feature?" She goes, "I don't know. I just go to the store and say I need shoes with more support." And I said, "Well, let me give you a different way to look at this, because nobody knows what that means." And so I have a handout. I can send it to you, Brad. I have a handout that I give out by the gobbles, 10 a day, just to educate patients. And it by no means isn't a cure-all, but it kind of gets everybody on the level ground. So they say, "Look, I changed my shoes, and it's made a big difference."
Somehow send it to me, and I'll try to figure out. This is how tech challenged I am, but somehow send it to me. I'll try to figure out how to post it on Doc Talk Live. Is that okay?
Yeah. It's I can easily send it to you. Years ago, when I've been practicing 20 years, similar to you, and I was at a meeting, and somebody had this idea, and I thought, well, that makes a lot of sense. So in podiatry, it's not something all podiatrists want to emphasize, but I'm a big fan of trying to start with the shoes and kind of go from that point and then start looking at other things. But shoes play a big role, whether it's...
What else for the posterior heel pain, the Achilles tendon insertion problem? What other shoe modifications would you make?
Great question. So a lot of times when you'll see patients say, it's always my right leg, and I never have problems with my left. The first thing I'll do is I'll check for limb length discrepancy to make sure that leg, usually that would be the short leg. So to answer your question, heel lifts a lot of times can help. Now there are times when both limbs are the same length, and sometimes I'll put a little heel lift inside the shoe of both feet. But usually, if somebody says, "Well, I always have hamstring problems, my lower back on my right side bothers me, now it's my Achilles," a lot of times, nobody's checked them for a limb length discrepancy.
How do you check for a limb length discrepancy?
As you know, there are multiple ways to do it. I try to make life simple. You can have all kind of scans done. I will sit the patient in a chair, get their back and butt all the way back even as much as I can, and then check for the medium malleolus, and that's where I start. And I make sure I recheck it again, and then I usually watch them walk too.
So you do it via inspection.
Yes.
By observation.
Yes.
I like to get an X-ray where they're standing and look at their sacral base, their pelvis,
Yep.
and see if there is some deviation there.
Yeah, no, that's good too. There's other scans obviously as well, but I try to observe them usually as I just described, and then standing and walking, and then see if there's something obvious that is easily noticed.
What about for this posterior heel pain? I know for plantar fasciitis we'll use these resting night splints a lot. What about for the posterior heel pain? Will you use a resting night splint?
Yeah, I think night splints are a good supplement, complement to all the other things I've mentioned or we discussed. I don't find, if you go on the internet, you would think these night splints are a cure-all from everything from the common cold to plantar fasciitis or Achilles tendonitis, but they're not. They definitely provide a relief, because the ideal scenario is that they're going to keep that Achilles tendon stretched so that when the patient gets out of bed, they're not re-stretching because it's already in that position. But I like them. I think that a lot of nowadays you can get them online, relatively inexpensive. So it's problematic when somebody has this on both Achilles tendons, or for that matter, both plantar fascia, because then they have to wear the night splint on both, or they alternate. But usually, I find the night splint to be more effective if it's a unilateral issue.
People are going to watch this. Lots of questions are going to come up. Do you have a website, Alex, by any chance?
I do not have a website, but maybe I need to get one.
I have one that just popped up.
All right, go ahead.
Okay. Are people with flat feet more prone to experience pain in their feet than those with higher arches?
No, not really. I mean, as we were talking with the analogy, the tennis players are playing again, we're trying to, I'm stereotyping foot types, but the point is that usually a flatter foot's going to have sometimes plantar fasciitis or more of the posterior tibial tendonitis, shin splints. A high arch foot would usually have more lateral symptoms, whether it's stress fractures, whether it's lateral ankle sprains, they're going to sprain their ankle a lot, whether they have femoral tendonitis. And again, I'm painting a big brush here, but I would not say that somebody with a flat foot is more prone to having problems with their feet. I can tell you from the athletes I've treated over the 28 years, I've worked at the D1, D2, and D3 level. I much would prefer an athlete with a flatter foot than a high arch foot. The Larry Gordons of the world, the Kevin McHale's of the world, both of them had a lot of moments from Bill Walton. They all had high arch feet. I didn't treat them, but I have friends. A friend of mine is a podiatrist for the Celtics, and I can tell you that all these players had high arch feet. Now, the Michael Jordans of the world, he had a flatter foot. Again, didn't treat them, know people that did. So, but usually an athlete with a little bit of a flat foot is less prone than a same type of athlete with a high arch foot.
Wow.
So just to sort of come to a little bit of a conclusion, not totally. There was a question here: is there a link between your feet and total body wellness? And earlier you said that the plantar fascia was the root of all evils. So I'd like you to sort of say a little bit more about that. Were you just kidding around about the plantar fascia just because so many people have plantar fascial problems? Or is there something to the plantar fascia in the rest of our body?
Well, you can go on the internet and see all kind of things that say if your big toe is red, that means you're going to have a heart attack, or, I'm not in any way suggesting any of that stuff. That's all nonsense. I don't know that one in any way as a podiatrist can pick up on any general health, wellness issues by examining somebody's foot. What I meant by the plantar fascia was kind of root of all evil. The flexibility of the Achilles tendon and plantar fascia usually can, or the lack of it, can predispose athletes to ankle sprains, to a whole host of problems. And a lot of times, the reason somebody is not flexible is that they've worn bad shoes for years. And once you get them into a change of shoes, or even orthotics, their plantar fascia is not overused, their flexibility becomes better, and some of these overuse symptoms, can improve. Now, I do want to make one comment. I generally can walk in a room by looking at somebody's feet, and I can tell just by the color of their skin, the tone of their nails, if they're a smoker or a non-smoker. And that's not, I think most podiatrists can do that. Usually you can tell if we're looking for connections between wellness. Usually patients that have, let's say, kidney problems, as are going to have more problems with venous insufficiency, leg swelling. So there's certain things that definitely there's a connection between other parts of the body or other systems, but I'm not going to in any way suggest that if you have big toe joint pain, that means you're prone to having a heart attack or anything crazy like that.
I'm going to switch gears on you because I called you and you basically said no question was off limits for you. So what my listeners don't know is that Alex really comes from a fairly famous family, not in a positive way, but more of a negative way. So your mom is a Holocaust survivor, and she went through quite an ordeal. And one, how is she doing? And two, how was it growing up in those circumstances with somebody who has been through such a horrible experience?
So, both my parents are Holocaust survivors. My dad's 92. Most people know my mom's story even core a lot better than my dad, but my dad was a 4-year survivor of Buchenwald, and my mom was at Auschwitz for about 11 months, and she's one of the Mengele twins. Joseph Mengele did experiments on twins. So how was it growing up in Terre Haute, Indiana, to two parents who were Holocaust survivors? It was different, it was strange, but for me it was normal because, at home we would have a normal life. My sister and I played sports, we talked about the news, politics, a little Hebrew, so we spoke Hebrew. But you know, it was very tough at times. I can give you a couple little anecdotal stories. When I was in 5th grade, we went to a PTA meeting and came home, and there were swastikas on our house. Go home dirty Jew, and this was 1974, something like that, 75 maybe, 74. And so for me, that was the first time I was ever in such a scenario. My mom, obviously, her thoughts immediately reverted back to her childhood in Hungary, Romania, Hungary. And so that was tough, because what happened, what ensued was that my mom would, believe it or not, start chasing these kids around, because they would come to the house and create havoc and throw corn at the house. And this became a big problem for me, because I'm in 5th grade, you know.
Sure.
School, other kids are saying, hey, what are you doing? Oh, Mrs. Core, she's kind of crazy. We're going to go over there. Now, we moved from that neighborhood. My mom got the bright idea every October, because it usually happened around Halloween, but every October she would go to Israel and see her twin sister. So the fun quickly died out, because my dad wouldn't chase the kids around the neighborhood. But, you know, nowadays, my mom speaks around the world, and the ironic thing about what I just told you is that very commonly she'll be in some obscure place, and she'll say, do you remember so-and-so? And I'll say, yeah. Well, they said they were at the lecture she gave, and they were one of the kids that, you know, created all the problems. And now, you know, things have come full circle, and kids that I grew up with that live in Indiana, their kids now come to my parents' museum. And so, to answer your question, my mom's doing great. We just got back from Auschwitz about 2 weeks ago, so she tweets a lot. She has 25,000 Twitter followers.
Wow.
I got on Twitter a couple of years ago just to kind of censor her tweets, but now she knows what she can and can't say.
Well, Alex, thank you so much for spending time with us. I look forward to having you back on. I look forward, hopefully this will grow into something more. We'll see. And it was really a pleasure. I appreciate you doing this.
Thanks a lot, Brad, and I appreciate your help from their studio engineer there, too.
I look forward to seeing you on the tennis court, too. We got to play some tennis.
That sounds good.
All right. Take care. Bye.
Bye-bye.